Hi, my name is Jones Muna. Today we look at active management of the third stage of labor. Aims: to prevent postpartum hemorrhage, to prevent infection. The active management: delivery of the placenta and membranes. Immediately after delivery of the baby, palpate the uterus with your left hand to exclude second twin. If there is no second twin, give oxytocin 10 UM within 1 minute of the baby's birth to generate a contraction. Wash hands and dry them. Deep gloves in JIC 1" 6 and dispose of them. Wash hands and put on another pair of sterile gloves. Explain to the woman what you are about to do. The mother should be in the dorsal position. Put a sterile receiver against a woman's perineum. Move the artery forceps close to the perineum. Empty the mother's bladder to prevent delay of the third stage. Wait for a contraction to deliver the placenta. Place your hand at the fundus of the uterus to feel for a contraction. When a contraction is felt, place one hand above the level of the symphysis pubis with the palm facing towards the mother's umbilicus and gently apply pressure in an upward direction and downward traction, controlled cord traction. At the same time, firmly apply traction to the cord in a downward direction. Using the hand that is grasping the forceps, only apply controlled cord traction when a contraction is felt. Apply steady traction to the cord until the placenta is out. If the maneuver is immediately successful, stop pulling and wait for the contraction and repeat. When the placenta is visible at the vaginal opening, cup it in both hands and rotate the placenta to rope the membranes. Use a gentle upward and downward movement or twisting action to deliver the membranes. Place the placenta and membranes in a receiver. Massage the uterus to rub up a contraction and expel any clots. Ensure the uterus is well contracted to prevent bleeding. Note: in the active management of the third stage of labor, do not wait for the signs of placental separation. Inspection of the birth canal should be done with good lighting. Swab the vulva with a sterile piece of gauze. Gently separate the labia and inspect the cervix for any lacerations and tears. Inspect the vagina for lacerations and tears. Inspect the perineum for lacerations and tear. Suture lacerations that need suturing. Wash the vulva and perineum with warm water or antiseptic solution and dry with a clean cloth. Place a clean pad on the woman's perineum. Remove soiled linen and leave the client comfortable. Give appropriate IEC, e.g. the woman should pass urine frequently, should breastfeed the baby on demand depending on the chosen feeding method. Clear, decontaminate, clean equipment and send for sterilization. Let her remain in labor ward for an hour. Wash hands and dry them. Document and report any blood loss and general condition. Examination of the placenta. Wash hands, dry them and put on gloves. Hold the placenta in the palms of the hands, maternal side facing upward. Examine the placenta for completeness check. If all the lobes are present and fit together, any lobe is retained, will lead to postpartum hemorrhage. Hold the cord with one hand and allow the placenta and membranes to hang down. Insert the other hand inside the membranes, with fingers spread out to note any part that could have remained in the uterus. Note the position of insertion of the cord. Measure the length of the cord. Average length is 55 centimeters. Average thickness of the cord is 1.5 centimeters. Inspect the cut end of the cord with the swab for the presence of 2 arteries and 1 vein. Observe for true notes. Weigh the placenta, normal being 1/6 of the baby's weight. Measure the blood loss and record. Dispose off the placenta by incineration or place in a leak-proof container for burial after consulting the woman about her cultural practices. Immerse both gloved hands in 0.5% chlorine solution. Clean surface area and decontaminate with 0.5% chlorine solution. Remove gloves and place in leak-proof container for disposal. Report and document in client's file. Infection prevention. Use sterile gloves and sterile equipment. Decontaminate all used equipment in JIC 1-6 for 10 minutes, then wash in soapy water, rinse, dry and take for sterilization. Clean the delivery bed with JIC 1-6 and rinse. Decontaminate gloves before disposal. Wear protective clothing, goggles, face mask, plastic apron. Environment: clean, warm, good lighting. Post-delivery recordings. Observations. Mother: the vital signs should be taken soon after delivery and recorded, then repeated after an hour, which the woman is kept in labor ward before transfer to the postnatal ward. Measure the fundal height and record. Check the vital signs of the baby, and the baby should be breastfed within 30 minutes of delivery. Let the baby remain with the mother for bonding. Complications of the third stage of labor. 1. Postpartum hemorrhage, the excessive bleeding from the genital tract of 500 ml and above at any time following the baby's birth, up to 6 weeks after delivery. Primary postpartum hemorrhage, excessive bleeding from the genital tract of 500 ml or more occurring during the third stage of labor or within 24 hours of delivery. It can be due to uterine atony, trauma or tears of the genital tract, coagulation failure. Signs include visible bleeding, maternal collapse. Subtle signs include pallor, rising pulse rate, falling blood pressure, altered level of consciousness, restlessness or drowsy, an enlarged uterus as it fills with blood or blood clots, feels boggy, soft, distended, lacking tone. There may be little or no visible loss of blood. Secondary postpartum hemorrhage is excessive bleeding from the genital tract with a blood loss of 500 ml or more which starts from the first 24 hours after delivery until the end of puerperium. It is most likely to occur between 10 and 14 days after delivery. Secondary PPH can be due to retention of a fragment of the placenta or membranes or a large uterine blood clot, infection. Signs include lochial loss that is heavier than normal and consists of a bright red loss. Lochia may be offensive if infection is present and subinvolution of the uterus. 2. Retained placenta. The diagnosis of retained placenta is reached when the placenta remains undelivered after 30 minutes of delivery of the baby. Retained placenta can be due to uterine atony, placenta ACCRETA. 3. Placenta ACCRETA is when the chorionic villi attach directly to the myometrium of the uterus. The adherence may be total, partial or focal depending on the amount of placental involvement. It is suspected when there is retained placenta. Treatment is abdominal hysterectomy because of hemorrhage. 4. Uterine inversion is when the uterus is pulled inside out or the fundus is prolapsed inside out as the placenta is being delivered and partly emerges through the vagina. It can also occur when the baby is being delivered. It can occur due to flabby, non-contracted uterus, pressure on the fundus. 5. Atonic uteruses, the failure of uterus at the placental site to contract and retract and to compress torn blood vessels and control blood loss by a living ligature action. Atonic uterus can be due to a full bladder during the third stage, incomplete separation of the placenta, general anesthesia, prolonged labor, etc. Signs include a flabby, non-contracted uterus. 6. Blood coagulation disorders such as disseminated intravascular coagulation, a situation of inappropriate coagulation within the blood vessels, which leads to the consumption of clotting factors. As a result, clotting fails to occur at the bleeding site. Coagulation failure or failure of blood to clot can occur following severe preeclampsia, antepartum hemorrhage, postpartum hemorrhage due to loss of clotting factors, intrauterine fetal death. 7. Hematoma formation, a hematoma can form in the perineum, vagina. It is difficult to diagnose if it occurs in the broad ligament or vault of the vagina. A large volume of blood may collect. Involution and lochia are normal, the main symptoms being increasingly severe abdominal pain. This is so acute that the hematoma has to be drained in theater under general anesthesia. Thanks for listening and kindly subscribe to my channel for more educative content.